Good morning, everybody. Welcome to an online event brought to you by Parkinson's Community Los Angeles. Today we're talking about pain and Parkinson's with physical therapist Dr. Apurva Zawar. I'm Julia Nichols and I serve on PCLA's board of directors. For those of you who don't know us, we are a non-profit that supports families living with Parkinson's disease through free events like this, support groups, and much more. Today, Let's Talk Parkinson's program is brought to you by our generous sponsors, Abbott, Boston Scientific, Kiowa Kirin, Medtronic, and Supernus, and by donations from the Parkinson's community. If you appreciate what we do, please make a donation on our website at www.pcla.org. Thank you. Just a few notes before we get started. We are recording today's event for YouTube. You will only be visible in the recording if you are speaking. Please stay muted to keep background noise at a minimum. And after the presentation, there will be time for questions. You can submit them through the chat, and we will also open it up for questions, spoken questions, if you are not able to type into the chat box. Please join me in welcoming our speaker today. Apurva Zawar is a passionate neurologic physical therapist, educator, and mentor. She owns and practices at Beyond Rehab, a digital neuro rehab and wellness clinic covering California, Massachusetts, and Washington. Dr. Zawar is a board-certified geriatric clinical specialist with expertise in managing movement disorders and persistent pain care. She has worked across various rehab settings in the US with highly expert multidisciplinary teams in treating neurological conditions. Her primary focus of work involves serving and managing complex care conditions such as Parkinson's disease. She strives to provide an intensive, total body approach to fitness, rehabilitation, and wellness. You can learn more about her practice at www.beyondrehab.health. Thank you, Dr. Zawar, for sharing your expertise with us today.
Thank you, Julia and team, for having me. I'm grateful and excited to meet everyone and present this topic. Good morning, everyone. Today, I'll be talking about managing pain in Parkinson's using a practical approach. As Julia mentioned, my specialty and area of practice is primarily Parkinson's disease, working with chronic pain management, long COVID, and movement disorder. So diving straight to the topic. So today, I'll be discussing about understanding the prevalence of pain in Parkinson's disease and its presentation across the stages in PD. Differentiating it from PD-specific pain from non-PD-specific pain, identifying what are the different types of pain in Parkinson's disease, and learning about non-pharmacological approaches and self-management care programs. How can they be helpful in managing pain in PD? So let's get started. So as we all know, pain is a very broad term, right? And its meaning changes from person to person, context to context. There's so many factors which influences the experience of pain. So one of the definitions by International American Society of Pain was defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So you might have noticed like the context of pain changes your overall pain experience. At times when you are in a familiar, pleasant environment, your pain experience is different versus in a new environment with too many stimulus happening, your pain experience is different. So in general, pain has multiple factors, multiple components influencing the overall experience. So we'll be working on better understanding, categorizing, and differentiating it. So it helps us with planning and treatment. So We'll start with recognizing the pain presentation, categorizing it, and differentiating it from PD-specific pain to PD unrelated pain, followed by planning and treating approaches for pain management. So first of all, it's important to differentiate pain from acute pain from the chronic pain. Acute pain is typically short lasting and it resolves with time as tissue injury heals. However, chronic pain is the pain which persists for a long time, roughly around more than 3 to 6 months. And at times, it might be a result of direct injury or maybe an insidious onset. It's difficult to associate it to the events at times. So that's the nature of chronic pain. So now focusing the presentation of chronic pain in Parkinson's disease. So studies have reported that Parkinson's patients have been confirmed to present with significantly higher levels of pain as compared to the general population. And also, since the time of diagnosis, almost 20% of individuals with Parkinson's disease have reported to present with pain. And later in the disease process, almost 80% of individuals present with the pain presentation. So pain is one of the most common non-motor feature in Parkinson's disease. And also it significantly impacts and diminishes the quality of life in person living with Parkinson's. So as we get started, I'd like to learn from you, when did you first experience or receive your Parkinson's disease? Was it in the last 0 to 5 years? And it was more than 5 years or more than 10 years? So I see like a mixed group. Majority of you have received your diagnosis in the last 5 years. Then like a good number and more that you have experienced it for more than 5 years. And then we have like a small group who have been experiencing it more than 10 years. The pain presentation, it's important to understand how the pain presentation changes across the course of Parkinson's disease. So one of the most common presentation in the premotor stage prior to the onset of the motor feature is frozen shoulder. It's a spontaneous onset of pain with restricted shoulder range of motion. And there is like minimal effect of any of the treatments to the frozen shoulder. It's been commonly reported as one of the most common presentation in individuals in the early in the disease, and it appears typically 1 to 2 years before the onset of motor features. Pain in early PD stage. In early PD stage, pain is related as one of the most troublesome non-motor symptoms, and it typically affects the side of the body where you experience most of the motor symptoms. Later in the advanced PD stages, pain is more common, and it's been reported almost 35% higher incidence of pain in the later stages as compared to the early stages. However, the characteristics of pain differs from early stages to the advanced stages, and there's a lot of variation of pain presentation in advanced stages versus in the early stage. So going further, I'd like to learn, how long have you been experiencing pain associated with the Parkinson's disease? Is it before being diagnosed? It's since the start of the diagnosis, or it developed later following the Parkinson's disease diagnosis? So right now there's a higher percentage of individuals who developed pain presentation following the Parkinson's disease diagnosis. And then we have also a good number of individuals who have had experienced pain before being diagnosed with Parkinson's disease. So it's typically more common following the Parkinson's disease diagnosis. And then similarly, the group has the similar presentation. Higher number of individuals experienced it following the start of the PD diagnosis. And also a good number of individuals experienced it before the diagnosis, and we'll be talking about each of it. So, as we are understanding, the prevalence of pain is one of the most common features in Parkinson's disease. It's also important to understand and learn what are the primary causes. Why is pain common in Parkinson's disease? So, pain in Parkinson's disease is multifactorial, it's complex, and it can occur during any time during the disease process. Studies have reported number of different causes related to pain in Parkinson's disease. One of the key causes like the lower pain threshold as compared to the healthy individuals. Pain threshold is lower in people with Parkinson's disease. uh, Secondary, the pain processing pathways have been altered, which results to change in the pain, which results to increase sensitivity of the pain pathways and increase experience of pain during the disease. Also, with the fluctuation of the motor and non-motor symptoms, also contributes to the pain experience. And lastly, the inflammatory signals um, have have been altered and which also contribute to the overall pain experience. This has been the primary causes of pain in Parkinson's disease. So as we are understanding, the prevalence is high. It's one of the common non-motor features, and there are different causes associated with it. The second step after understanding the prevalence is to identify what and differentiate the pain in Parkinson's from the pain non-specific to Parkinson's disease. So let's start by solving these questions together. I'd like you to grab a piece of paper and just answer all of these questions together so we get to solve and screen the pain in Parkinson's from pain unrelated to Parkinson's disease. So the first question is, is your symptom started or become more severe since the onset of PD? So just put down yes or no. The second, do you see the worsening of pain when your rigidity, tremors, or slowness of movements are more intense? Basically, do you see any fluctuation in pain with your motor symptoms variation? Followed by, is your pain associated with excessive or abnormal movements, like more of dystonic movements, dyskinesia? Is your pain associated with it? Lastly, does your pain improve when taking PD medication? Do you have like a positive effect of pain during the on phase versus the off phase? Do you see any variation? Um, think about it. Put the answers to all of these 4 questions down. When you're ready, I'd like you to move on to the next question. If you answered yes to any of the questions in the previous slides, then the pain is considered as PD related pain. And if not, if it's negative to all of the questions, it's more unrelated to PD. So I'll like you to classify your pain. Is it pain related to Parkinson's disease or pain not related to Parkinson's disease? So majority of you so far have pain related to Parkinson's disease. It's really important to differentiate pain as it will help us in designing and planning the treatment. So the treatment when it's pain related to Parkinson's disease is different as opposed to pain not related to Parkinson's disease. So now, once we have this information and once we are able to classify if it's related to PD or unrelated to PD, followed by that, we need to further characterize the PD-related pain, right? There are so many variation of pain presentation. So there are 3 characteristics features of pain syndromes in PD-related pain. One is nociceptive, neuropathic, nociplastic. I'll be talking about each of it. So the first one is nociceptive pain. So the nociceptive pain is triggered by the nociceptors. It's primarily referred to as the pain receptors. So we have pain receptors all across the body, tissue, muscles, joints, and organs, and it gets triggered by internal or external stimuli. following the actual or threatened damage. If they sense any kind of actual or potential tissue damage, those receptors, the pain receptors, get activated, and they send signals to the brain and contribute to the experience of pain. So the simple example is anytime when you're sitting in a wrong posture, or you're, for instance, if you're just bending on one side while working, after a certain time, you might get those unpleasant sensation, the joint stiffness, tightness, relate signals that your posture is wrong. There's some discomfort, and that will trigger you to change or modify the posture. Those are the common presentation when the receptors get activated and send the signal to the brain about the discomfort or any kind of tissue irritation happening in the body. Also, when you're standing close to a warm or heated surface, all of a sudden you will get that the receptors, the nociceptors, the painful receptors activated, sending signal, it's danger, don't go forwards, don't touch forwards. So that's how the nociceptors receptors get activated, and they communicate those signals to the brain, and it helps in formulating the pain experience. So this nociceptive pain, it includes most of the musculoskeletal pain syndromes, meaning any kind of trunk deformities like kyphoscoliosis, like forward posture, increase in side bending, excessive side bending, dropped head syndrome. All of these contribute to the musculoskeletal pain syndromes. Joint disorders like frozen shoulder, adhesive capsulitis, dystonic joints, joint pain related to osteoarthritis and other inflammatory conditions are commonly referred as the nociceptive pain. Secondly, also the pain arising due to the motor fluctuation, right? If you experience pain during the off period, painful dystonic spasm, or as well as peak of dose pains, those are also referred to as nociceptive pain. So the dystonia pain, like when you experience any of the pain during the off phase, in the morning before the first dose of levodopa, or even during the medicated period, that's when that's when it comprises of musculoskeletal pain. It happens because of the change in the motor motor symptom fluctuation, and it's together primarily characterized as nociceptive pain. Secondly, neuropathic pain. So it's a pain associated with the disease of the nerves, peripheral or central somatosensory system. It's basically experienced as burning, electric shock-like, and pins and needles sensations across the nerve root. And at times, it's exacerbated because of the change in posture. So the simple way to understand this neuropathic pain is if you see burning, electric shock-like sensation, and you experience it across the back of your leg, in the arms, and it's all across the arm and across the nerve root region, or it's more specific. It's like pins and needles, you feel it very intense. That's when you classify it more as neuropathic pain. Lastly is the nociplastic pain. I know these terms are different, but once you're just able to understand it, it will be easy to classify it. The nociplastic pain is similar to the central pain. It's very vague in presentation, and it's not specific to the single pain region. It's diffused across the body. At times, it can be described as stabbing, burning, vague. It has a very diffuse presentation, and it's not very well explained. The features like leg motor restlessness, visceral pain, non-motor off pain can be classified as nociplastic pain. So these are the three different types of pain, different characteristics of the pain, features associated with it. I'll like you to take some time and label to the best of your understanding. It was I know at times it needs more information to help you categorize your pain presentation, but with the information available, how will you best classify it? Is it like more musculoskeletal pain? Is it more like nerve related pain? Or is it more like central pain, like very diffused, vague? It's all across the body, not local to one region. This is a quick screening tool. It might not, we might need to, further talk and dive into it later, but based on the available information, if you see more of your presentation resembling to any of this. Okay, so I see majority of you have more of the nociceptive pain. It's almost 68%, followed by the neuropathic pain, 42%, and last is the nociplastic pain. So now, as you understand your pain presentation, the characteristics feature of your pain, and you categorize it into different buckets, the next step is rating your pain level. So in the past 1 week, how was your pain intensity on a scale of 0 to 10? 0 meaning no pain, 10 meaning extreme. So how will you rate your pain? Followed by the frequency. Is it mild, moderate, severe on a scale of 1 to 3? Lastly, impact on your daily life. So is it like mild impact, moderate impact, and severe impact? So once you have those numbers together, you can multiply it and have the score. Just it's one of the screening tools. It's just a reference point. So you can just, like, if it's, for instance, 2 into 2 into 2, so just like 8. So put it down. So this is just a way for you to categorize your pain and rate your pain level. How is it? Okay, so moving on to the next, the key part is how do you manage it, right? That's really important. So as you see, management of pain in Parkinson's disease involves multimodal structure. So the primary goal of using non-pharmacological approaches in management of pain in Parkinson's disease is to help you empower with tools and skills necessary for managing pain, reducing the reliance on medication, and actively participating in physical and social activities. It's important to learn about the different approaches, different components which will help you manage. So the big goal is to help you actively cope, actively learn, understand, and manage your pain. That's the way to that's the one of the most efficient way to help to understand, to interpret the pain, learn new techniques, repeat and progress, and manage it with minimal reliance on medication. And the best part is it's all driven by you. So learning these tools and techniques, practicing it, repeating it, advancing it will help you efficiently manage and cope with pain. So how do you do this? When you're looking into the non-pharmacological approach, it involves different components. First is pain neuroscience education. So understanding the nature of the pain, right? Right now we were learning about the different characteristics of the pain features, how is it presented, when it occurs. So also learning about the ways to interpret the pain, what are the common triggers which influence the pain presentation, how do you better work on relieving the symptoms, better managing it, followed by learning about ways to optimize the healthy lifestyle routine. It's very crucial to have continue building the healthy routine, which is it's essential for having the healthy environment, which helps you better cope and better manage pain, followed by reconnecting and retraining. So working on gradually returning back to the exercise, practicing neuromotor exercise training. And lastly, flare-up management, learning about tools and skill sets necessary for managing pain during the flare-up episodes. This is also very crucial. So imagine you have you have a good week, and all of a sudden there is a sudden rise in the pain level. So during those time, how do you cope with the pain? How do you what tools and techniques do you use to manage pain during the flare-up episodes? So together, all these skills will help you build the resources which will be essential to manage pain. So I'll be diving into each of it together. So the first is pain neuroscience education. So one of the first steps in achieving this goal is through understanding the science of pain. It's important to promote neuroplasticity. So neuroplasticity is the way is one of the ways where the brain neural networks in the brain reorganize themselves. So how do you do it? So you start by understanding how pain is experienced, identifying the underlying triggers, learning how to better interpret and manage it. So pain neuroscience education, it's essential to learn about what are the ways you interpret pain and accordingly manage it. The biopsych, looking at the pain presentation, right? It's multimodal in nature. So many components contribute to the overall pain experience. So it's important to understand what are the possible triggers. Is your pain associated more in relation to the disease and bodily health, your health condition, your tissue pathology, the systemic changes, stress? Identifying that is it more related to the biological changes happening around the tissues, the joints, and overall body health. The second is understanding, is it more because of the emotional wellness related to your overall mental state, your motivation, your stress level, followed by the social. How's your interpersonal factors such as social interaction, community engagement, lifestyle, social support, access to care? All of this together contribute to the overall pain experience. So just putting some thoughts, understanding when you experience pain, what are the possible underlying factors? What are the possible triggers? Is it just like if you are standing too long, that's a possible trigger? Is it if you're walking uphill that changes, or if you're in a new environment, your pain presentation changes? So learning and diving into each of these components will help you better understand and relate to the overall pain experience. Followed by this is, as you're working on this journey of better managing pain, it's equally important to work on optimizing your healthy lifestyle routine, meaning working on healthy eating. Anti-inflammatory diet is one of the most recommended diet. It helps when decreasing the inflammation. It's recommended a good sleep hygiene of at least 6 hours of daily sleep, regularly engaging in the fitness activities based upon your level, and mindfulness practice, either through the formal forms of body scanning, meditation, mindful movements, or through informal ways of just being present with the activities, with situation, with your present environment, and just focusing on being in the present moment. Those are the different ways which you can continuously work and progress, and it boosts your overall healthy lifestyle routine, and also promotes the neuroplasticity, and which is crucial in helping you manage, cope with pain. Looking into each of these components and rating yourself, like, where do you need more help? Do you need to look into the diet pattern? Do you need to look into the mindfulness practice? And considering different options and starting the training will help you. The followed by the key component is reconnecting and retraining. Typically, because of the pain presentation, your activity level, your exercise level decreases, because at times it results in increase in pain experience. So gradually working with the specialist, with your provider, with your team on integrating sensory training. It's one of the ways where you help in desensitizing the nervous system, working on gradually improving your sensory integration, followed by motor training. It involves gradual exposure to improve activity level and increase your confidence with activity. followed by functional training and exercise. It's more related to returning to the Parkinson specific exercise routine to help you improve overall motor and non-motor Parkinson symptoms. So it's done in step-by-step pattern. Definitely it involves an assessment of your presentation, where do you see deficits, and then gradually planning accordingly. So this way you get to you get to add those training routine and gradually advance with time and with repetition. So as you're integrating exercises, there are few key features which I'd like you to keep in mind. So anytime when you think your pain is more nociceptive, in other words, musculoskeletal, look into targeting the muscle strength, deficiency, mobility, functional impairment. If you see your pain is caused more because of the posture, it's more because of the forward head posture. So looking into it, like how do you work on strengthening the back muscles? How do you work on improving your flexibility? How do you reintegrate the functional training gradually? So doing it with the team, doing it with the with your PT, whoever you work with, will help you. Followed by neuropathic pain. So it's important to look into the nerve root presentation, the features, and then looking into adding the neural limb tension tension test trainings to help you gradually desensitize the nervous system and increase the activity level. Followed by nociplastic pain. It's more of a central pain, more of a diffuse pattern. So it's looking into grading physical activity and progressing to the aerobic exercise and functional training as tolerated. So this is just a recommendation. Keep in mind when you're working and when you're adding and changing the routine. So this will help you better plan and better add different exercise to your daily care. So as we are talking about exercise, at times you might have experienced exercise triggers pain, brings soreness, muscle irritation. So how does it then, why should we do exercise when you have pain? What's the benefit? So exercise is important because it helps you improve and promote the neuroplasticity and neuro restoration. It's one of the ways where a brain changes, learns, and organizes itself to help you better interpret, better cope with the pain. And it happens with positive stimulus, right? Like if you're gradually increasing your activity level, if you're gradually understanding the pain presentation, interpreting it rightly, and working accordingly, will help you promote the neuroplasticity and will help you build up the tools, build up the resources necessary for you to move better, feel better, breathe better, which is really important for you to manage your pain. Followed by this pain, exercise also helps you in modulating the pain pathways, pain inhibitory pathways, which will help you in overall better understanding and interpreting the pain. So those are the benefits of exercise for managing pain in Parkinson's disease. Definitely, it needs more rigorous, more careful approach. So think about it, talk with your provider, and accordingly integrate it. It's also important to understand and create a plan for flare-up management, right? The days when you're not able to feel good, or you have a sudden spike in your pain presentation, what's the plan? What are the tools and resources which you need to go to or practice so you're able to efficiently manage it? So there are different ways. The simple way which I'll recommend is start by creating a diary. Just put down what are the ways which you can avoid flare up. Is it working on simple regular stretching? Is it focusing on pacing, making sure you're not doing all activities in one row, dividing your activities, pre-planning, dividing it across the week so you're not overexerting yourself. Putting down a plan for it accordingly. When you experience the pain, when you experience the flare-up episode, what do? What's your way to relieve the muscle tension, relieve the overall flare-up episode? Do you have some Do you have some simple tools like, heating back, some foam roller, whatever's relevant to your presentation, simple exercises, music, just phone a friend, whatever different components which helps you better calm yourself and interpret the pain, putting it down together, and just start with the process. With time, you'll be able to have a list and work accordingly, and practice. So it takes some time, but having a plan to address it will help you. So as we are learning about the non-pharmacological approaches, I'd like to ask you, what type of pain management treatment do you currently receive? Is it medication, interventional procedures, physical therapy, psychological therapy, complementary therapy, or surgery? So I see a good a good divide between medication, over-the-counter and prescription, and physical therapy, and also complementary therapy, like acupuncture, yoga, meditation. Okay, so medication is one of the most preferred ways, like over-the-counter or prescribed. Almost 64% of individuals use it for pain management, followed by physical therapy and complementary therapy. Okay, thank you. So as you're managing pain, it's equally important to have more of an integrative approach, meaning you're working you're working with the different providers, you're communicating, collaborating with with your entire team. It needs a multimodal approach to help you better manage it, and communication, collaboration will help it. So anytime if you're receiving pain medication, if you're seeing your pain specialist, make sure you're communicating with your rehab providers, you're communicating with the neurologist, so everyone's aware of your treatment approach and can keep that in mind while planning the treatment. So this is the overview of entire simple steps which you can start looking into understanding how non-pharmacological approach will help you manage it. So one last question is, how much does your pain impact your ability to engage in physical and social activities? So I see a mix of minor, moderate, significant impact. And again, it depends, right? From day to day, overall week, and other bodily presentation and changes happening around. Okay. So now, all these options were just to helping you understand, these are the ways where you can start looking into, integrating this into your daily routine to help you better manage pain. So where do you begin, right? That you have all of these resources. How do you practice? How do you repeat? How do you learn and continually progress? So one of the common ways to continue practicing, learning, and engaging in these type programs is the self-management pain and PD program. It's becoming more and more popular in our healthcare systems. The goal of these type of program is to help you become an expert on managing your pain by helping you better understand your pain presentation, learning about ways to alleviate your fears, concerns on about pain and activity, helping you become more fitter, stronger, despite of your pain, and creating a toolbox of skills and techniques and exercise which will help you stay active, stay healthy, and return to the previous activity level. So on the similar lines, at Beyond Rehab, we offer Parkinson's Power Up program. It's a 4 weeks long program. It's designed in the similar fashion to help you learn more about pain, work on reconnecting, retraining, building your tools for flare-up pain management, freezing episode, and gradually re-engage. It's done in a group setting, a small group of 4 to 6 individuals, and the goal is you meet 4 times a week, 8 times a week, twice a week, for 1 hour each, with regular assessment, regular consultation to help you understand your baseline, create a plan, practice, repeat, and progress accordingly. It's been well received by the communities. It helped it helps to overall improve your pain understanding, help you build the active coping skills. This is really crucial. It shifts your health and well-being responsibility from the healthcare professionals to the individual. Re-engage in life activities, decreasing the fear, increasing the confidence with movement and social engagement. So this program has been very well received by the communities. Individuals have had good experience. They were able to report decrease in reliance on over-the-counter medication by 20%, and also improve in engagement and return to the exercise programs, group programs, which they were not able to previously participate in. So it just there's some good comments here. One of them said it was a new tool sets to fight the pain, and it works better than Tylenol and pain patches. Thank you. So thank you for this time. Thank you for coming and joining me in this pain talk, and I'll be happy to answer your questions now.
Thank you so much, Dr. Zawar, for sharing your expertise with us today. We have one question in the chat box, which is, how often is Tylenol okay?
It just depends. It's hard to answer it. It depends your presentation, what medication you're taking. There are too many factors involved. I'll suggest connect with your primary care doctor or your movement disorder specialist to learn specifically about the frequency, the dosage for you.
Thank you. We have another one in the chat box, and then I see Suhegi, you have your hand raised. Please go ahead and unmute yourself and ask your question.
My question is, I'm 39, I'll be turning 40 this year, and I've not been diagnosed, but I do know that Alzheimer's and Parkinson's disease runs in my family. So I guess my question is twofold. One, is there, like for breast cancer, for example, any genetic testing that can be done to see if you are more susceptible to Parkinson's disease or not? And then my second question is, what preventive measures can we take, to prevent from, if it can be prevented? Again, I know part of it is genetic. So, and thank you again. Happy to be here with you.
Great question. So I don't have any answers to it. The studies for, early diagnosis are coming, but nothing yet is clear on, nothing is clear yet, like, typical features which we need to look or screen for Parkinson's disease. It's just keeping an eye, continuously communicating, connecting with your doctor, and that will be a good start. But no direct answer to how to pre-diagnose it or look into the early features.
A couple of questions were related to the Power Up program. How many times a week and how long for the Power Up program? And secondarily, can you tell us more about the exercises and tools in that program?
So the program is 4 weeks long. The group meets twice a week. Initially, before the start of the program, you receive one-on-one consultation to understand your baseline assessment, your goals for the program. And then the program is built upon different components, right from education, neuromotor training, repetition, functional training, and building the tools and skill sets necessary for you to manage and cope with the pain. So it's multifaceted. The good thing is it's done in groups, so it's more dynamic. There's a lot of exchange of information happening throughout the time. And then following the end of the program, the group continues to meet once a month. If they are interested, it's just like a support group, and we continues to exchange information, share updated evidence and other related information around pain management in Parkinson's disease.
Lovely, thank you. We have another question in the chat box, which is, what is the cost of the program?
The cost of the program is around $600, and it depends, on a couple of different factors. So just depending upon number of individuals who participate, so it's around 600 if we have certain number. So, but it's again the flexible scale. If you're interested, just reach out. I'm happy to talk and answer other questions related to the pricing and your pain presentation.
Other questions? Anyone who has a question that would like to unmute, say your name, and if you have a question for Dr. Zawar, we'd love to take any spoken questions.
Can you hear me?
Oh,
Yeah.
yes, we can.
Okay,
Is that
okay.
Arthur?
Yeah, I've got about 3 or 4 questions. Is that okay?
Yeah.
You know, this is really delightful because, first of all, I've had about 8 years of Parkinson's, so I'm not new to it and I'm not old to it. But my sense is that people who undergo physical pain as opposed to emotional pain, because you didn't address emotional pain, but you did in your definition. And I know you're a PT, and God, I love what you've presented. It's so helpful. But the question I'm leading up to is, how do you sort out the population that undergoes emotional pain versus physical pain? I mean, is that 80% or whatever that high figure you gave? Is that wrap up the emotional and the physical in one group?
Yes. So the pain experience is typically, mix of physical, like your sensory, emotional, and cognitive processing experience together formulate the pain experience. So the number 80% is related to your overall pain experience.
Okay, so that's a great point. What I think from your PT perspective, wouldn't it be helpful also to separate out the physical from the emotional? Because, for example, someone who presents with an emotional issue may be more inclined, let's say, to deal with psychotherapy and that avenue. Not that PT doesn't have a significant role. I mean, maybe I'm being contrary here, but it seems to me the folks that have the physical manifestations are the ones that are going to gravitate towards you. How does the emotion, maybe that's another separate subject, but that's just something I had a thought on.
Yeah, no, definitely. Like the pain experience depends, overall how's your emotional health, how you're perceiving stress, your motivational factors. So anytime if we see the emotional piece is limiting individuals in their physical activity, that's when we work hand in hand with the psychologist, working, helping them have a plan, have a more sessions, more time with the psychologist. And if there are any barriers for them to continue with their physical engagement or manage more of the physical symptoms, that's when they work with us. So it needs more of a team approach, and everything is so well interlinked, and definitely it's hard to say pain is just it's related to the physical symptoms or emotional. It's a mix of all.
Okay,
So
that's great. Let me just get to a specific in my case. I have tremors in my toes. Okay, that's where it particularizes. And I had initially hammer toes that are curled. I don't know if you can see my. Anyway, so I had them surgically elongated, but I knew from a physical standpoint they looked normal, which they were because they were not curled. But the tremors, which my theory is that the tremors, because when it shakes my toes, that to me is the genesis of that is caused by the tremors. So one of the interesting aspects of, for example, deep brain stimulation is, yes, it can eliminate those tremors, but it doesn't necessarily eliminate the pain. And that's, maybe I'm being a little complicated here, but it is complicated because you would think if tremors are occurring, which I can see they are, and I can feel, then, and they create pain through just the muscular movements of those, they get tired and cramped. Why in, for example, the case of DBS, and I know that's not your expertise, but why can't, if it addresses the tremors but doesn't eliminate the pain, where's the disconnect? Assuming that the tremors are the trigger.
So I'll answer it in two different manners. So the first thing, if you're experiencing tremor and that's contributing to your pain experience, at times the tremor symptoms can be managed with the change in medication dosage. So if you're seeing your movement disorder specialist in coming months, give them more accurate information. When do the tremor starts? Is it just during the start of the off phase, or is it just early in the morning? And see if there is any room to change the medication dosage. That takes care of the tremor at times. Secondly, looking at more of the physical components, the motor fluctuation, there are from the physical therapy standpoint, you can work on addressing the motor control changes, working on strengthening, improving the flexibility, and working on sensory training, which will change your pain experience to some extent. And along with working on the pharmacological side with your movement disorder specialist, together it will help you better manage, better cope with it. It takes time, but collaborating with two different teams will help you do it. And when it comes to DBS is more, it's not recommended for the pain. It's, as you said, it's more for, managing your motor symptoms, improving your motor presentation. There's no correlation of how, because the pain pathways, the pain processing pathways, how it works doesn't change or alter with the DBS surgery. So that's one of the factors why DBS might not be helping you with pain.
Yeah, I guess I don't understand how the physical aspect of tremors are not what it seems to me that they're saying that tremors are not associated, they're not the genesis of the pain. They're not causing the pain, but what is causing the pain? If I know that my toes are tremoring, how can you say that there isn't a correlation there?
Definitely there's a correlation. So tremor, it's more of an excessive movements of the certain part of the muscles. So because of the excessive movements, so there's more of a muscle irritation, muscle spasm, or muscle changes happening around. That's when, the painful receptors, they get triggered and they communicate to the brain, and they contribute to your overall pain experience, if you want to just look into the simplified version. So when you work at the physical, more at the primary level, working on retraining the muscles, strengthening the muscles, better managing the motor symptoms through training, through exercise, through different components, that will change your pain perception, overall pain experience. And simultaneously, when you're looking into addressing the tremor piece from the pharmacological standpoint, that will change your frequency, your tremor presentation. That will be one component. And the second is, because of the tremor, whatever changes are occurring in the surrounding tissue, that can be addressed through a physical therapy piece. So together, it will definitely change your overall pain experience, and it will make your tissues more, more tolerant, more capable of managing it with decrease in pain overall experience.
That's great. Thank you so much.
At this point, we have to wrap up because we are over time. So I apologize if anyone had a burning question. You can still feel free to send us any questions and we could forward them. But I would like to say a huge thank you to Dr. Zawar for being here today and for sharing her expertise, and just for everyone to learn more about pain and types of pain and how to manage it. So we thank you.
Thank you.
And we are just going to wrap up by saying we are very excited to say that PCLA has been chosen as an official charity partner of the LA Big 5 race, which is part of the Los Angeles Marathon. If you are in the Los Angeles area, we invite you to join us for the LA Big 5 on Saturday, March the 18th to help us raise funds for our support groups, our education programs for our Parkinson's community. So please do join us. Today's event was made possible by our sponsors, Abbott, Boston Scientific, Kiowa Kirin, Medtronic, and Supernus. And by you. By donating to PCLA, you can join us in our mission to improve the lives of families in our community who are living with Parkinson's. PCLA is a non-profit and all donations are tax deductible. If you enjoyed today's program, please consider donating at pcla.org to help us continue our work and continue to provide programs like this for free. And as always, you can reach out to us with questions at info@pcla.org or by phone 310-880-3143. Thank you, everybody. Again, thank you so much, Dr. Zawar.